Good morning. Colleagues, can please take your seats. We know it's a busy day, and so we're going to go ahead and get started. We do anticipate that others are going to be trickling in over the course of the conversation, but it's really a pleasure to be with you all today. My name is Kate Dodson. I'm Vice President for Global Health at the United Nations Foundation. And it is our pleasure to co-host today's open briefing, I think 10th since 2015, with the Global Health Center at the Geneva Graduate Institute, where we are today. Thank you for hosting us, Sueri and her team, and thank you for all your work to get today to happen. Today's conversation in this open briefing, we've chosen to center on the theme of WHO's 75th anniversary. I see many of you wearing the t-shirts already. You're well aware that this is WHO's 75th year. The thing about anniversaries is that they're often said to be only important to the people in the organization that's celebrating them. But the thing about WHO is that that's all of us. And the billions of people who rely on a strong, well-resourced, and highly functioning World Health Organization for their health and well-being. So we'll focus on that for a fair amount of the conversation this morning, but not at the expense of a session on our hot topics, which is a perennial favorite at the open briefing, and I'm grateful to Professor Gianluca Bersi for leading that session this morning. I'm grateful to the panelists who will join us and the moderator who will come and spend a good hour with audience engagement and participation on the topic of WHO's 75th anniversary and what this week may tell us about the organization's strengths, its challenges, and how it can be fit for future purpose. We'll have a conversation that ranges from the vantage point of governance, from government leaders, from non-state actors, and from people who have played multiple of those roles over their tenure, including at WHO staff. We'll then have a segment, deep dive on the context of fragile and complex operating environments. This is arguably the biggest litmus of whether or not the general program of work and the SDGs writ large will be achieved. WHO noted the other day in their World Health Statistics report that more than 339 million people are living in fragile and complex settings, almost 1 in 20 of the world's population. That's an increase of 25% since just last year and double since 2015. So as we get underway, I'm going to do a little bit of housekeeping before I introduce our co-host, Professor Sueri Moon. One note, we do have simultaneous French and Spanish translation. You can pick up headsets in the back. The speakers will be speaking in English, but we do have that available.
This initiative, and I think Switzerland is one of the sponsors, basically to empower WHO through its technical work to contribute to peace, to contribute to conflict resolution, to conflict mitigation, and so on. So there is a roadmap which is supposed to be endorsed by the Health Assembly. So that's a decision item. And then polio, which is being slowly phased out. But if you look at the agenda, there are two long reports. One is basically terminating the job of the Secretariat. The other is how countries are moving out of and transitioning out of polio. And then finally, political issues. Besides Taiwan, you have Ukraine, obviously. There was a resolution taken last year. There is another one, I hear, one proposed by Ukraine, one proposed by the Russian Federation that may be discussed. So you can see some fireworks in Committee A. I haven't spoken about the famous pandemic treaty or the international health regulation because they're not really part of the agenda. There is a progress report on the pandemic treaty, so just for information, no action, and there is nothing specific on the IHR. But tomorrow there will be one of these secretariat briefings at lunchtime on these negotiations. So I'm sure there will be a lot of discussion, a lot of side conversations among delegates on breaking some of the deadlocks and so on and so forth. So I'm stopping here. I see Kate that is sort of calling me to order, and if there is any question, I'll be happy to respond. Many thanks for your attention. any question? I've been exhaustive and perfect, but just in case some tiny details have escaped. Yeah.
Hi. So my name is Stephanie Bergam. I came here with the G4 Alliance, which is focused on surgical, obstetric, trauma, and anesthesia. And so I was actually looking into the Global Health for Peace initiative. Could you maybe talk a little bit more about how this would affect like conflict zones, and specifically policy inside of conflict zones? Like, we know that sometimes a lot of resolutions can go dismissed by it. How will this like ensure that, let's say in the security and peace agenda, health is like maintained?
Yeah, good question. It's a pretty long item. There are long reports on this, and it's nothing new. I mean, if you remember in the past, they had like a moment of truce to vaccinate children during armed conflict. So it has a long tradition, a long legacy. But fundamentally, is to equip WHO to basically turn health issues into something that promotes peace, either by giving evidence on the impact of armed conflict, or to give it more operational tools to try to inject itself into situation of armed conflict. Obviously, WHO is not a Red Cross. It is a very different mandate. But sometimes health can be an argument for a moment of peace, a moment of truce, to allow vaccination, to allow health interventions, and so on. But I think the item is broader than that. I must say I haven't read it all. It's very complex and long. But the idea is to provide almost like a blueprint to show that health can be a contributor to peace, or there can be a moment of basically breaking deadlocks in political negotiations, in armed conflicts, and so on. So as I've seen, it's fairly broad and generic, but it gives a blueprint to the Secretariat, basically, to provide analysis and to propose ways of stepping in situation of conflict. I invite you to look at the documents. There is also a document which is not in the agenda of the Assembly, which is basically the blueprint, because it's fairly complex and very elaborate. But that's the extent of my knowledge of the item, I think. Okay, do I have 1 minute?
Apologies. Thank you. Thanks very much, Gianluca, for this overview. I think we couldn't put many things here on this slide of main issues. We all have our pets and our favorite agenda items. I really love to see on the agenda of this year, among all those things considered under item 16, the return of the political, the overcoming this kind of fragmentation of health into many, many small pieces. We have a sub-item on social determinants, and we have a sub-item on health and well-being. I think this is really something which needs all our attention also, so, because I think this is where a World Health Assembly also can make a difference, putting those two elements which are so core, so at the core of the World Health Organization, back to the top of the agenda. So have a look at those ones. Thank you.
Yeah, definitely.
I'm Thomas from Medicus Mundi International. Good to be here.
Yes. Yeah, no, definitely. As I said, I could only give a couple of examples, but as you said, there is an item on social determinants of health, an item on personal disabilities. So there are many technical items that are absolutely important, and that to me is one of the one of the elements of importance of the Health Assembly, because sort of people talk about epistemic communities, communities of practitioners and scholars that share the same language. And to me, that community comes together around technical items like this. Even with political divisions, there is like a common intellectual, professional language that makes a big difference, what you don't see in the General Assembly, for example. And to me, what the element of importance of specialized agencies, which is the communities coming together. So I totally agree with you that some of these items may pass unobserved or may seem less important, but are absolutely essential. Should I finish? Yeah, okay. Many thanks, and on to the next speaker. Thank you very much.
Thank
Thank you very much, Gianluca, for that very comprehensive overview of what is coming down the pipeline and how everything works. Indeed, let's see what kind of political fireworks we may or may not have this week. It's my pleasure now to give the stage to Dr. Tedros. He is expected to be in 50 different places at the same time this morning. So we are delighted that he can join us by video, and I believe my colleagues have that queued up to welcome all of you to the open briefing, to the assembly. The downside is, of course, that he's not here with us in person at the moment. The upside is he will stay right on time and hopefully get us back on schedule. So.
Esteemed guests, dear colleagues and friends, since WHO was born 75 years ago, the world has made extraordinary gains in health and well-being. Life expectancy has increased from 46 to 73 years, thanks to sharp declines in maternal and child mortality, smoking prevalence, improvements in water and sanitation, and much more. Smallpox is history, and polio is on the brink. And the epidemics of malaria, HIV, and tuberculosis have all been pushed back. Of course, we still face formidable challenges. The rising tide of non-communicable diseases, antimicrobial resistance, vast disparities in access to care, the climate crisis and air pollution, and as COVID-19 has taught us, the ever-present threat of epidemics and pandemics. This year's World Health Assembly, like every year, is a vital opportunity for countries to meet these challenges, to promote health and prevent disease, to progress towards universal health coverage based on strong primary health care, and to strengthen the world's defenses against emergencies of all kinds. The challenges of today are very different to those we faced in 1948. But the vision is the same, the highest possible standard for health for all people. I thank you.
Thank you very much, Dr. Tedros. It's now my honor and pleasure to invite on the stage our moderator for the next session, where we'll be looking at WHO's evolving role in global health governance. I'm delighted to invite to the stage Dr. Amy Maxman. Many of you will have read her work throughout the years of the pandemic, covering COVID-19 for Nature. Perhaps more recently, you've read some of her work in the Washington Post. She's an award-winning journalist who has been reporting for many, many years on science, on health, on political questions. And we're really delighted that she can be here to introduce our panel and to guide us through a discussion on WHO looking back over the past 75 years and looking forward for at least another 25 years. So please join me in warmly welcoming Amy to the stage.
Well, I guess I'll just go ahead and just start the panel because I think that might be the quickest thing to do. So I'll just call up the panelists. The first panelist is Dr. David Heyman, who I've been talking to for many years. He's an infectious disease professor at the London School of Hygiene and Tropical Medicine. And he also played a big role in revising the international health regulations in 2005. There's Dr. Suet, who, oh no, trick chair. Okay, I'm glad he's okay. Dr. Suet, who's a senior advisor of the Ministry of Health in Thailand, and also on the steering committee of the Asia Partnership on Avian Influenza Research. We have Dr. Yodi, who I've also enjoyed speaking to in the past. She's co-chair of the African Vaccine Alliance and special envoy at ACDE. Dr. Patrick, who's director of health at the Ministry of Health in Slovenia, and also chair of the WHO Executive Board. And I'll take a seat too. So, is this on? Okay, great. So to start with, I thought I might start with Dr. David Heyman. Because you were involved with the last revision of the International Health Regulations 20 years ago, just to reflect on that a little bit. It was a different time. Specifically, let's talk about information flow. So now with the internet, as well as like improvements in sequencing technology, et cetera, there's a whole lot more information. It flies around a lot more quickly. It's not so limited. So when it comes to the WHO's role in collecting information and synthesizing it and interpreting it, how has that changed now as we look to amend the IHR?
Well, thanks, Amy, and thanks to the Graduate Institute for having invited me. You know, the IHR were developed back in 1969, and their goal was really, if you look at it, was to stop disease at borders. If a country reported one of 4 infections, cholera, yellow fever, plague, or smallpox, then countries that were receiving passengers from those countries could request a vaccination certificate for yellow fever, for example, or for smallpox. There were predetermined measures to occur at borders to stop disease from entering countries. At that time, WHO was the exclusive owner of much of that information because countries reported to WHO. WHO did a risk assessment and then provided these recommendations to the world. By 1995, however, it was understood that the coverage of the regulations was really too small. 4 diseases were not what was important in the world today, where there are many emerging infections. And so there was a resolution in the World Health Assembly to revise the regulations. That really didn't pick up much momentum until 2003, when there was the outbreak of SARS that occurred with spread around the world. At that time, it was understood that borders really cannot stop disease. It was understood by epidemiologists many years before, but the political leaders understood at that time borders cannot stop infection. And so there was a revision, and that revision was very useful because, number one, it broadened the scope of what would be reported, and that was a potential public health emergency of international concern. And that sort of is a safety net. A country is to report a potential public health emergency of international concern. The Director General can then, in fact, call together an emergency committee and decide whether or not it really is a public health emergency of international concern. He makes the decision based on recommendations from the emergency committee, but from many other advisory bodies as well. So his decision is made after the emergency committee meeting. That committee then makes initial recommendations. What we saw was, though, in the second part of the revision, which is, in my view, is the most important, is a requirement of countries to establish core capacity in public health, to be able to detect, respond, prevent national spread and disease and death, and eventually prevent international spread by this rapid reaction. So that, to me, is the heart of the revised international health regulations. The regulations are also to be able to do these risk assessments and to determine whether there are public health emergencies. And that's being done, and that was done during the COVID pandemic. But as we saw in the COVID pandemic, countries really preferred doing their own risk assessment. They had access to data which they had never had before. All medical journals, all respectable medical journals, were publishing peer-reviewed information in front of their paywall. So any government advisory group could get that and could make recommendations to their own government as to what to do. And what we saw was there wasn't a unified way, and they did do their risk assessment, or in the border requirements that they had, and there was confusion, utter confusion in the world during that. And WHO was not able to have the authority, for some reason or other, to put normality into that, those recommendations which were being made by countries. So as a result, we have the regulations now, and to me, they're really a vestige of the past.
Yeah, thanks a lot. Sort of speaking about countries sort of deciding to do what they wanted to do in the pandemic, maybe I'll turn to you, Dr. Kirsten, because you chair the executive board. So how do you make on the executive board, how do you make sure geopolitics and sort of political concerns outside of health are not going to take over some of the areas of coordination, cooperation that we wish we would have among members of the executive board?
Okay, thank you for your questions, but I'll start with asking myself in front of you what actually is WHO. You think it's a stupid question? Well, it's not. It's a very important question. The WHO is not secretariat. The WHO is even not, all these people now in the World Health Assembly and the EB and everywhere. The WHO actually are we people, all of us, because this way or the other, we all impact what then happens under the umbrella of WHO. Why am I saying this? Because that is what led me when I took that chair of EB. I was very much aware that sitting on the chair does not actually change anything with me. It gives me a role, though, that, as I learned from advocacy, could be very important. People suddenly tend to think that because I sit on that chair, I know better than the others, which of course I don't. So my role is to pass the messages from other knowledgeable people to audiences that should hear and don't hear when people try to tell them, but they don't hear them because they are not speaking from that chair. So that is very important to understand when I talk to you. I understood very well that I depend on what others think, know, and would like to share and even would like to then be done in the way. So before becoming a chair, I was running around asking all the delegations, not really all because it was impossible. This was last year in the World Health Assembly. And I was talking to so many people, and everybody was totally unhappy with how we work. They said, there are so many statements, everybody is saying this and that, they're all right, but nothing happens, and we don't exchange, and EB is catastrophe, because at the end of the day, we don't even listen to each other. And when it comes to the statements of the NGOs, everybody is already so overwhelmed with all the information. We don't cope with this. So you are talking, NGOs, because I heard you are many here, but nobody's really listening. So I said, okay, something could be done here. So what I, in discussion with others, and many things came from the others, not from me, tried to change the ways of working a little bit. So we were piloting new ways of working. Something was mentioned before. Gianluca said, instead of having separate statements, hundreds of them, let's compile them, and some NGOs, that work together could have one statement, so at least they would have some chance, to be heard. I said, well, me as an EB member, even, I want to know what NGOs are saying in advance, because this could impact what I'm saying at the EB, and my voice is heard at the EB. So that is why I proposed that you post those statements on the web before things happen, before the EB starts. So me, as a responsible person, would go there and read, or at least read those things that I'm after myself, or I think are important, So I would know exactly, NGOs are after this, and I will get some great ideas, because as I said, sitting on the chair doesn't make you any more clever. So that was the main thing I was after as a chair. And you know what? Everyone supported me. It was incredible how much support I got and how much good ideas indeed were passed to me. So we tried to improve. There was agile member state group, these are agile countries, whatever does this mean. Very important though. They do a great job. They try to improve our ways of working. They were listening to us. We were working together. And many ideas that we discussed at the EB, finally, were in their report and proposals for changes. You will hear of this. We are there, us EB members. That was one thing. The other thing that I realized is that WHO, yes, it's a normative organization, Gianluca, yes, I know, it's the more normative organization, but actually we are continuously speaking of implementation. And who is the one that will implement? It's us countries. WHO can serve us. It can support us with evidence, some technical support. They can do it. But it's us countries most of the times that should move things in the direction that we are so eager about here in the World Health Assembly. I'll give you one example that is super frustrating. We all know what the best buys are. Somebody here doesn't know what the best buys are in alcohol policy, tobacco control, obesity, and so we all know. These are actually measures that are cost efficient even, so the countries don't have to pay much. If adopted, they really make a big change. Are we adopting those measures? No, we are not. So who is adopting these measures at the end of the day? Our parliaments, aren't they? Our governments should be, pushing for it and so on. We are not doing this. So when I started to speak, I said, who is WHO with an intention? It's us member states. We are the ones who will, at the end of the day, make sure that things get done. And just the last thing that I consider super important is that we are continuously repeating, nobody left behind. Do we really know what we are talking about? No, we don't, because we don't even know what the needs of those most vulnerable people are, and we don't figure it out how to even assess those needs. What about address those needs? These are hidden populations. Sometimes these are populations that you also have said so nicely are in the crisis area where WHO cannot even enter, but the NGOs do enter, and they are there, and they work with these people. So FENSA, all this process, very well done, fine. But does this equip us to work better with NGOs when we are implementing? Not. I don't think so. We should pay in the future much more attention how countries, hand in hand, the governments, the local governments even, work with NGOs, because these are the ones who can assess and address the needs of most vulnerable. And they need us, and they need expertise and WHO, because them as well are not always the most knowledgeable in what works and what doesn't. So they need WHO. So working together would be really a solution. Thank you so much.
That's a lot. Thank you very much. And I think you gave me a very good jumping off point, to go off of, nobody left behind and these sort of calls for solidarity. How do you actually make them real? So Dr. Yodi knows I'm already about to ask her a question, which is, above the level, so certainly working with civil society and NGOs is very important, but above the level, so you had a very close look at ACT Day, and also maybe we can talk about the pandemic accord just briefly, but what are the big barriers with distribution? We saw horrible distribution around the world with diagnostics, vaccines, and drugs during the pandemic. What do you see as some of the big barriers or what needs to happen to make sure that countries and people aren't so left behind?
Thank you, Amy, and thank you very much, the Graduate Institute and the hosts for having me. It's lovely to see you in person. We all look so different online, so this is a real honor and a privilege to be here. I also want to make note of the fact, last time I think I saw David was when I rushed into the London School of Hygiene and Tropical Medicine, January 2020, having run over across from Fiji because I was convinced the world was about to end and PHEIC had not been declared, and you had just come back from Geneva the day before, and we were saying, where do we go? So it's fascinating to hear the process. Thanks for your question. I love what Vesna's just said, we the people are WHO. That's really important to hear, but your question was about what went wrong during the pandemic, because it went horribly wrong. Mm-hmm. And was it a problem with distribution? I would say what went wrong was power. It was about power and it was about greed. And I think we have to be very clear about that up front, that it was not an issue of distribution. It was a fact that we have a world that is horrendously imbalanced in power, and I think a lack of understanding of the historical moment that we were in, where we have seen this power and this greed and the outworkings of it, and now we're hearing over 22 million people in excess deaths, and we're seeing that play out in the geopolitical space and the geopolitical arena because people are angry and because people were left behind. And to go back a little bit, I mean, I wear two hats, and I wear the hat of the chair of the Africa Vaccine Delivery Alliance, which John and Kegasong set up under the AU, and which I now go on to chair since he's now gone on, and we've transitioned that into the Africa Countermeasures and Readiness Alliance. But I also continue to wear the chair of Special Envoy to the Access to COVID Tools Accelerator, which continues its activities. And those two things are linked because there is a misunderstanding that the world, not just Africa, but that the world was waiting for Act A. But the world wasn't waiting for Act A. Before I was appointed to join Act A, I was appointed into Act A 22 months into the pandemic. Things had already started to go very, very wrong. But before that, we, Africa, many other countries of the world, also the Pacific Island countries that I also am part of in a way because my parts of my family are Fijian, we're desperately trying to find countermeasures. We're desperately trying to find diagnostics. I remember my spa therapist in Fiji, bizarre, yes, but my spa therapist in Fiji and one of my close friends ringing me from Fiji to say, Yodi, do you know where we can get tests? I remember speaking to ministers and people across Africa, but my own country, Nigeria, where we were paying $150 for a diagnostics test. And so there were no diagnostics, so people said there was no COVID. But of course, there was COVID, it's just that we couldn't test it. And like some world leaders said at the time, if you don't test for it, you won't find it. So we didn't test for it, we didn't find it, and not only were we left behind without diagnostics and vaccines and eventually Paxlovid and treatments, but we were also left behind in data. And so now today the world is looking at long COVID and the effects of what's gone on beyond COVID, and the world again has forgotten and left us behind. Left behind because we were not listened to. So I don't want to just go to Act A. I think it's important that the world understands that our countries try to purchase these items. We try to use our own money because when people talk about Act A, they think, oh, well, Africa and the rest of the world were waiting for charity, we're waiting for donations. No, we were not. We were trying to buy our own. And the world has to understand that the charity model does not work. It does not work in a pandemic. It will not work, and we have seen that. And the two key things I've mentioned before, it was greed. It was greed from high-income parts of the world in many ways because people bought more than 10 times what they needed and pre-bought. So when we got to market, and I was very much a part of those discussions with the Africa Union at the time, when we got to the market, we were pushed to the back of the queue because they said that they would have to fill, the drug companies would have to fill orders for many, many other countries before they got to us. But it was also a lack of recognition of what was going to happen. And I think we underestimated the human instinct to hoard. It was like that whole thing with toilet paper. Do you remember that? It was so bizarre. I mean, toilet paper. People were hoarding toilet paper like COVID was the great apocalyptic diarrheal disease. I mean, we misunderstood that it was not only that it was airborne and not only that it was not just a respiratory illness, but it was also a vascular illness, but we also thought we were all going to poop till we died. And therefore, we hoarded toilet paper. And this is what the presidents and leaders of the world did. But the role of the pharmaceutical industry also must not be understated in this. So what we're saying now, and I see you going to your microphone, is that yes, it was greed. Yes, it was the imbalance of power. And we have to somehow rebalance this world in a way when we look at, we're shifting IHR now and look at how we address diseases and how we address outbreaks. But we have seen how it plays out in the geopolitical space, and it was wonderful to see my dear big sister and mentor walk in right now, Ilona, as she and I talk so much about the role of politics and health policy and that. And there was something also that David said, which is really important, of when politicians began to understand in 2003, when SARS broke out, was when politicians began to understand. 2003 is a pivotal moment in my life, because I also understood outbreaks there as I was walking across a road in Chiang Mai, Thailand, going to speak at the Harm Reduction Conference in my previous life in the Pacific. And I was hit by a truck walking across that road, yes, literally, hit by a truck in Thailand, and woke up in Melbourne, Australia, because they were afraid of SARS and because already people were then wearing masks. And yet we didn't learn those lessons. We didn't learn the lessons of SARS. We didn't learn the lessons of HIV/AIDS. The question now is, will we learn the lessons of COVID? Will we learn the lessons of COVID that are also telling us that COVID is not just a respiratory illness, and that even now, as we're dealing with communities of people living with HIV, we're going to, for the rest of possibly our own lives, be dealing with people living with long COVID and the sequelae of that. So the lack of access, the inequities in access have not ended yet, because as I see studies now being done on what is going on with people with long COVID and how, my last ACT A meeting, which was on Thursday, we were talking about new generation vaccines for the next iteration. And yet nobody has vaccinated the majority of the low-income countries of the world for the first iteration. We have a long way to go.
Yeah, for sure. And I think yeah, it's very important. Just a lack of recognition of how things will play out, because we probably have a very good sense of how they play out, but it's convenient to not think about that. Just to move on to our other panelists, Dr. Suet, one thing I'd love to ask you about is sort of, again, looking back at the last 75 years and looking forward. Thailand and many other countries are very different than they were even just a couple of decades ago. There's been economic growth in a lot of countries, including Thailand, which are now upper middle income countries, and so therefore less reliant on sort of a traditional role of the WHO in terms of, helping with healthcare, because now Thailand can provide most of its own healthcare. But also we have new kind of challenges coming up. Countries might act more regionally than internationally. There's an aging population. We have climate change with all sorts of natural disasters. And I'm just wondering, how can the WHO, which was created in a different world, evolve now to the current world, and one that we can predict will happen in the future? And perhaps you could speak to some of Dr. Yodi's points in terms of, can we also be honest about really the relationship of wealthier countries with less wealthy countries?
Thank you, Amy and Suri. First, I would like to confirm with you that this lady, Christina, is the best executive board chair I have ever seen. In my 25 years experience with the WHO governing body, she did excellently. And if you want to know anything about World Health Assembly and Executive Board, you go to Gianluca. He is the one who knows everything and ready to respond to you promptly, faster than all the WHO secretariat. You asked me about our country evolution. Looking at myself, the first time at the Health Assembly in 1997, I dare not open my mouth, just sit in my seat and waiting for other country to lobby me to sign my name to support their resolution. But nowadays, we propose agenda. We propose draft resolution. We walk to member states to support our resolution. Not because we are moving up from middle-income country to upper middle-income country, but because we have teams that commit to it. Member states must feel that we own the WHO, no matter how useless it is now. I can guarantee that it is a standing death organization, but she didn't ask me this question, so I will not touch on it. But even though it's near useless, we can make use of it in 4 ways. 1, we use it at a school. Gianluca mentioned that the delegation, 2 to 50. Thai delegation has never below 50. This year, 59. We have global health diplomacy workshop, global health diplomacy fellowship program. They are students. They come here to learn and to make intervention. Imagine a young chap from the developing country put up their flag and make intervention in the plenary, in the committee. That's a big, huge opportunity for leadership building and also understand global health. 2, we use WHO to back up our activities, our policy in the country. We propose agenda, and then we get the resolution. And then we use this resolution to go back home and inform everyone that this is the WHO resolution we should do. The second use. Third, we use the WHO name to even push for legal structure. Legal structure. When we were discussing on the bill for control of the marketing of breast milk substitute, the parliamentarians were lobbied heavily by the milk industry, even the pediatric and OBGYN association. And one day, our prime minister went to UNGA for the high-level meeting in September. Then the ambassador convened a dinner for all the delegates to join, because that year there was an agenda on AMR. So health was part of the delegation. When the prime minister walked into the room for the dinner, his face was not happy at all, serious. Then he called Minister of Health, please come to me. And then they went into a private room. After 1 minute, my minister came in and said, Dr. Sweet, please join me. I didn't know anything. When I walked in, Prime Minister said, what did the Ministry of Health do? The private sector, which I have just met, the US Chamber of Commerce or something, informed me that the Ministry of Health is doing something on milk to make them cannot do business. What can I say? Can I tell him that, oh, breast milk is good, we should support breast milk? With limited time, I just say that, oh, sir, this is the agreement at the World Health Organization. In the National Code, Milk Code, since 1981, many countries already have legal structure to back up, but not Thailand. And he said, oh, if it is international agreement, go ahead. You see, name of the WHO. Then not enough. We are afraid that it may not enough. We asked the DG to send a letter to our Prime Minister and the parliamentarian supporting this bill. Just a drop of an ink, so influential. This is how you use the WHO. Everyone in this room, including myself, pay the tax to our government, and we pay contribution to the WHO. So all the WHO staff, including the DG from the senator, work for us. They're not our boss, we are their boss. So we must make use of them. And you can make use of them if you build up your capacity. If you are like me in 1997, come there and sit very afraid of everything around, and pile of document that your speed of reading is very slow. You see? So thing has changed, not because of from middle income to upper middle income, because if you invest in capacity building, you can make use of this useless organization.
Because we started a little bit late, I thought maybe I'd open it up to the audience for some Q&A. Okay, in the back.
Great to see so many of you on stage. Rupa Dutt, Women in Global Health. You know what my question is going to be, but I'm going to preface it with the most recent data that we released at Women in Global Health, where we looked at women's representation at World Health Assemblies all the 70 plus years that World Health Assemblies have been happening, what we have found is that 85% of those representations have included male delegations being the majority. There has been not a single World Health Assembly where women have been represented as the chief delegate, more than 30%. Yet when you take a look at health workforce, women deliver health. How are we going to change this narrative? How are we going to break away from the past of 75 years of global health governance and really make sure we have equitable representation? And not just women, Yodi, I'm nodding at you, but women from the most underrepresented backgrounds. Suit, especially turning to you, and you know, when we talk about UHC, we know we are not going to be able to achieve UHC without gender equality and women's role and representation. So how do we break away from the past? Thank you.
Thank you. Thank you, Rupa. I really want to respond to that and say that we can't just also be tokenistic about including women at the table. We must support women. We must understand the transactional cost of being a woman in positions of power and corridors of power. Those transactional costs are often not just financial, they're emotional. We need support systems. And so we need to understand the wider, broader scale of it. And, you know, often what we do see now is that people and women from sort of, say, Africa or Asia or the Pacific are brought forward, and that is great. But what we need to understand as a global community, and I hope this will come up in conversations at the World Health Assembly, is that when you are pulled forward into those roles, it can be hell as the only woman in the room. It is intimidating, and oftentimes you often have to overcompensate to try to, you know, to try to fit into that space. But our structures and the institutions must themselves recognize the difficulties and the challenges and the transactional costs therein. So it's not enough to say that we have male allies, but what is the institution doing? What are the institutions doing to support that, that allyship role? What are the institutions doing to ensure that women, that, you know, to use Kamala Harris as an example, that she is not just the first, but that she would not be the last. Because oftentimes women are set up to fail because there isn't the requisite support. So, and half the sky is women, all the adjective or the whatevers you want to throw out there. It is not just that. I mean, let me look at, you know, crisis, and my previous life was conflict and crisis as chief humanitarian coordinator for Nigeria. I also saw that in that role, because dealing with a crisis, nobody was looking at the women and girls issues. When the IOM were building shelter in the sort of integrated humanitarian space, when they were building shelters, they built shelters all together, and they built them near the bush, not recognizing the young women in the Lake Chad region, when they went to the bathroom, were being raped, because there was no woman thinking about that. You know, and so anybody in town, unless I speak a lot in idioms, because and my language, which means that the person who wears the shoe knows where it pinches, because language matters, culture matters, and it is us women who understand the importance. Let me go to COVID. No, there were no studies done at the beginning on vaccinations, on vaccines for pregnant women and lactating women. I worked together with Heidi Larson at London School and some people at Bill and Melinda Gates Foundation at the very beginning, because women were not being vaccinated because nobody had done any studies. Why? Because all of the people at the heads of the organizations and at the, you know, the big boys, as I call them, they were women. It wasn't out of wickedness. They just don't get it. And so I couldn't agree with you more, Rupa. And yes, we're seeing more come forward, but we need to speak, not just that we need to have women at the table, but we need to support women at the table to pull other women up. Thank you to Women in Global Health for the incredible work that you do. And there are women in this room who have supported me, who have, you know, had my back at days that in the last 2 years that I've literally been in tears. You know, I'm looking at one of them on the front row. I'm looking at one of them at the back over there. There's so many of them. And we have to not just women support each other, but institutional help to ensure that Women in Global Health is not just a tagline, and that all women can come along. Thanks, Amy.
Yeah, that was a beautiful answer. I see a question, this gentleman right here in the middle, semi-back.
My age being more than the combined age of all people in the audience, I can remember and compare. And if I try to compare the medicine as it was half a century ago and today, I would say that the big changes are the advent of medical devices like the scanners of all kinds, the deciphering of the genome and all the therapy it allowed, the advent of some novel drugs. I wouldn't mention Viagra not to offend the person who asked a question before me, and the evolution of medical profession with more and more fragmentation overburdening the the insurance system. In this, I see very little relevance of WHO. These are totally disconnected worlds. So apart from being good or bad, isn't the WHO just beside the point or out of the world?
Okay, please, Dr. Kirsten.
It's very interesting how you put it. I would add to your list something that happened, and it's seriously super important, and that is access to information. This is what has happened in the recent years. Everybody, even a child, can access information on health, on what cures you or what doesn't, you know, what you should eat or what you shouldn't. And in fact, that is a big, big danger, because people, we are not yet equipped with all the knowledge, you know, to be able to distinguish between evidence-based and based on commercial interests, if I am super clear here. So now a lot needs to be done, but where? Probably we have to start with children. We are speaking of health literacy, and yes, there the WHO again has a leading role. We, WHO, are the people who have to work now with education, the governments, whoever, you know, to install mechanisms, you know, in the schools that even children will start being educated in how to actually cope with all this information there and use it for their benefit, not using for the benefits of somebody else. So that here I see, you know, that WHO has a huge role. And really I wanted to point to this because this still is not discussed appropriately. Not even in our organization. It's like we cannot do something. We are looking at all these people that, you know, we call them anti-vax, but these are people afraid of vaccines. And we say, oh, disregard them. No, talk to them. You know, I'm talking to them. It's really not nice, but I am talking to them because I can see their fear, and I can see how some of them are manipulated by some other people who have, again, the commercial interest there. And I could discuss this in length, but I'll stop here.
Wonderful, thanks. You know, we're gonna end, I'm gonna end soon. I thought I would just ask my own question, just to end it on. So another thing that maybe was revealed by the pandemic, so many things. One of them was that, you know, the WHO, or as part of IHR, there were assessments to see how well countries were prepared for a pandemic, like the joint external evaluation, and there were others external to the WHO too. And we saw that that didn't really completely work out, especially I know it was made to show where the gaps were, but for example, my own country, the United States, came out as being very well equipped, and in fact, we were not. So maybe I'll ask David about this one. What happens? Do we just kind of tweak the assessments or scrap them? Is there something else to look at?
You know, in the medical sector, I think there were three things that have been learned from the pandemic. The first is that you need strong public health. You need good prevention, you need good One Health activities before events occur, and you need to make sure that you can do the contact tracing and other activities necessary. But we also saw that you need a surge capacity in health facilities, and you need at the same time that those health facilities can provide routine care to people who need it. We saw in the Ebola outbreaks in West Africa, malaria was a much higher killer than Ebola ever thought of being because children could not access health care. the health system had collapsed. So preparedness is not only public health, it's good, strong surge capacity and universally accessible health care. But in addition, it's also healthy populations. And the countries that had the most serious outcomes from the pandemic are those with the most people with comorbidities and obesity. And if we don't include health promotion, effective health promotion, in preparedness in the future, we won't be able to deal with pandemics that are caused by an infectious agent. So there are three interlocking functions that weren't looked at during the assessments on the JEE, and they are good, strong public health along with surge capacity, continuing access to health care, and healthy populations.
So it sounds like you're saying tweak it. Yodi, you have a point.
Yeah, I have a real quick point into sort of linking those things, what you just said also to what the last gentleman and Vesna said. And I'm going to speak from a practical perspective. I'm a practical person. I tell people I'm not very clever, I'm just practical. So in my previous life as Chief Humanitarian Coordinator of Nigeria, I'm going to use the outbreak that we had during that, which was a cholera outbreak. And this speaks to WHO and how WHO works and how it interacts with countries and building national capacity, etc. As Chief Humanitarian Coordinator, I was contacted by the WHO office in Nigeria and said, Dr. Alakaja, we have a problem in northeast Nigeria where there are IDP camps of over 2.5 million people. We have cholera. I made a phone call to our government to speak to people at high level. There was very little movement at the time. I reached out, and then another gentleman from WHO, Jorge Castilla, Emergencies Department, reached out to me. Dr. Yodi, help, we have a problem. Between WHO, Geneva, WHO National, the country office, the Nigerian government, and NGOs on the time, between Jorge and all of those incredible people, we were able to reach out to Gavi and get 990,000. No, it wasn't million. Was it million? It was million. No, it wasn't million. It was million doses of cholera vaccine into the country within a week. Those were cascaded down to the NGOs and the CSOs on the ground in the Northeast who had been funded by incredibly generous funders who had been funded through our humanitarian appeal, and they went out and they vaccinated millions of people in less than 2 weeks. We stopped that outbreak. So for those who say that you don't need a WHO, you don't need multilateral institutions, I give you that example because in the countries where you sit, you may not need them because your health systems are strong enough. But in the countries where we sit and where I live, I would not be alive if it weren't for WHO. And so, yes, I'm over 20, but just. Excuse me? Oh, okay. Okay, 30. But in our countries where we live, this institution is still vital. It is vital because we are building health systems. It is not an either or, it is both and. We need WHO, we need strengthened national health systems, we need strengthened regional institutions, but it is the national institutions and the local communities and the CSOs and NGOs on the ground that will truly deliver health for all where it is needed. Thanks, Amy.
Wonderful.
Very short. Jody, it's not only in your countries. My country, Slovenia, would reverse tobacco legislation if it was not for Article 5.3 that I use it when I had to discuss things in the parliament. So we all need WHO. It's not only the countries in Africa, definitely not. We all need it very much.
Yeah. Thanks. Well, that was a perfect ending. I'm going to close this session. And thank you so much to my panelists. You're all wonderful and amazing. Thank you.
Thank you so much indeed to our excellent panelists and moderator. I think you've taken full advantage of the more open atmosphere in an academic institution that we were hoping to provide with this briefing. And in particular, I'm grateful that each of you has been so frank in your views of WHO at 75 and looking forward for the next 25 years. Please join me again in thanking our panel. So let me now introduce our next session, which is a fireside chat And I'm really delighted to invite up onto the stage my colleague Stéphane Boussard. He is a reporter with Le Temps, which is one of the big francophone daily newspapers here in Switzerland. He's also one of the most, I would say, the keenest and sharpest observers of international Geneva, as we call it here, including WHO. Previously, he's covered the United Nations in New York, as well as other developments in New York. And I think he's one of the best qualified journalists, I would say, to moderate the fireside chat. I'll let him introduce the two speakers. Just a couple words, why are we focusing on health in crisis? As we just heard from some of our previous speakers, we are already in an era of polycrises. WHO's role has evolved, will continue to evolve over the next 25 years. And one thing that I think is very clear is that WHO's role in crisis and in conflict will become increasingly important, as we see with the agenda item on this week's Assembly, Agenda of Global Health for Peace. So without further ado, let me invite Stéphane up, who will introduce our panel.
Hello, everyone. Thank you very much. I think, Suri, you've been too kind to me. Now I'm under tremendous pressure. Well, we had a fascinating panel discussion. Now we'll carry on the conversation now about an issue of very high concern among health authorities, which is health in conflict settings. And to talk about this, I'd like to invite on stage two excellent speakers and very insightful speakers, experts on this issue. Rana Hadje, she's Director of Program Management for the Eastern Mediterranean region at WHO. And Dr. Esperanza Martinez, she's Senior Manager for Organizational Resilience at the International Committee of the Red Cross. Thank you. And we're going to talk now about, how actually in conflict setting, how is it like to handle health issues, and how does it impact the triple billion targets. So maybe to start with, I'd like to start with you, Esperanza. Help us understand the impact fragile and conflict settings have on global health, and maybe can you explain with concrete examples how difficult it is to deliver health services in a context of war, such as in Ukraine, where it's a given. We know that many health facilities, maybe up to 700, according to the latest figures, have been destroyed.
Thank you very much for the invitation as well, and for putting this theme within this discussion. So I think to understand the impact of armed conflict and violence on global health, we just need to look at the statistics. More than 2 billion people are estimated to live in situations of fragility, vulnerability, or armed conflict today. And 2 billion people is 1/4 of the world population. And some estimates say that half of them, so 1 billion, will be in extreme poverty by 2030. And we know through the social determinants of health that poverty, armed conflict, and insecurity are drivers of bad or poor health outcomes. So that's one issue. The second one is we look at, and humanitarian organizations were mentioned before, but for example, for the ICRC, we work in more than 80 countries today supporting health systems together with health authorities. That is a significant number of countries that are affected by armed conflict and violence. And of those, there is an estimated 60 to 80 million people that today live in situations of governance by non-state actors. And here, non-state actors are not international organizations, but armed groups. So 60 to 80 million that don't live until the governance of a state, and still that have health needs. So I think when we look at that, we see that the scope of the problem is big. When we see that the signals emerging globally today for further armed conflict are flashing red across different continents, the situation is worrying. And if we add to that the likelihood of another epidemic or the likelihood of a potential deterioration of the climate situation, then we are looking at a broader impact on public health. But what does it mean for health specifically? Armed conflict. And armed conflict and violence are probably the biggest disruptors of day-to-day functioning of people, communities, and systems. So people have to seek shelter from bombing, that is happening today in Ukraine, from gunfire, what's happening today in Sudan and so many different countries, from insecurity, from gang violence in Haiti. So there are so many countries where the day-to-day just doesn't happen. And systems are also impacting. Supply chains are broken, communication systems are not available. In many countries, internet is the first thing that is shut down when you have social unrest. And that prevents people from seeking healthcare. And also another aspect which is critically important is healthcare facilities and healthcare workers intentionally or collaterally are attacked and their services are disrupted. And I would say finally one aspect that is a very big challenge for ministries of health and for WHO, but in general for communities, is that the burden of disease changes. So when you have armed conflict and violence, you need to focus on emergency care and on trauma care. And unfortunately, that comes to the detriment of maternal and child health, NCD management, elderly care, preventive medicine, and also surveillance for epidemics and pandemics. So it's a whole range of issues which makes this quite an important item to keep in the agenda moving forward.
Thank you. Dr. Hadji, how would you actually characterize the way WHO has been operating on the ground in conflict crisis, in conflict settings, and in health emergencies, and how it should operate in the future, maybe? And I was wondering also, is it a positive evolution, the fact that WHO, a normative organization, becomes more operational?
Thank you very much, Stefan. And first, maybe just to say good afternoon and really thank you for having me. That's the first time I participate in this forum, and it's really a pleasure to be here with this audience. I have to say, I didn't think it was a great time for a fireside chat, but Geneva is still pretty cold for somebody coming from Cairo. And I really enjoyed the previous panel. It is a tough act to follow, but thank you for the opportunity to highlight some of the issues. Esperanza already touched on it, but allow me, before I get directly to your question, I promise I will get to it, to mention some statistics. And I would like to focus in particular on people in humanitarian need, because that's a huge population. And I actually, just to make sure I got all the numbers correct, so globally there's something over 300, almost 340 million people in humanitarian need. And that's actually quite an underestimate. I mean, as you know, we're always, not to refer to Dr. Suit's comment, I mean, I guess I know we can be more useful when we are generating better data and more timely data. I know you meant it very lovingly, but I like our data to be updated in a much more timely fashion, but we think this is actually an underestimate. And in our region in particular, and maybe it's actually, I'm grateful to be here for EMRO, because EMRO, our Eastern Mediterranean region, a region of 22 countries, at least half of them are in conflict, and the others are directly affected by the conflict because of neighboring countries. Almost over 120 million out of the 300 million are actually in our region. So that's a huge, and of course, you know, many of these crises, the recent crisis, Afghanistan, you know, Ukraine crisis has also affected all of us, and Sudan, not to mention the least. Some of the issues and why WHO's role has to change. Many health issues in conflict that don't come up. First, right now, conflict and emergencies in general are the top threats to reaching SDGs. Of course, we are all very late, and the reason I like to remind this because we are in 2023, we have barely 7 years to go, and COVID, if anything, has delayed us. So, and the humanitarian and emergency crises are not helping. So it's a great time. I think it's a great time, and it's really fitting that we are celebrating 75th anniversary of WHO. We have a lot of work to do just in the next 3 to 4 years if we want to catch up with SDGs, and we have to deal with the humanitarian issues. Some of our some of the countries, just to highlight why the humanitarian and conflict are critical, Afghanistan and Somalia, 2 countries in my region, are the, they have the highest child mortality rate, for example, and among the top 10 for women mortality, and that's mainly because of the conflicts and the issues they have to deal with. The disruptions in day-to-day health services, the need to reach essential health services is completely compromised, like we are seeing. If not, many of the health facilities are directly targeted, like what we are seeing now in Sudan, which is really hard to believe. And often what happens in such situations is that it's a convergence of issues. Because of the conflict, then you are more at risk for outbreaks. 70% of outbreaks in the world occur in countries that are actually in conflict or fragile situations, 70% of outbreaks. Because, why? Because there is no strong health systems. Many of the countries have suffered from protracted emergencies. These emergencies have significantly weakened the health systems, and this is really important to bring up in the context of a humanitarian, because, I don't know how many donors and partners I see here. We have a lot of academics, a lot of other partners. The donors have focused during humanitarian crisis. The funding focuses on dealing with the acute humanitarian issues, which is very critical. Food, shelter. I mean, I grew up in Lebanon during the civil war. When you are hit by bombs every day, your main concern is barely even health. Is first to stay alive, if health is relevant, but food and shelter and water. There's some very basic necessities, and that's usually the focus of this. For us as WHO, we have focused on the safety and security of our staff, ensuring people have access to essential services, strengthening capacities to at least prevent outbreaks. I mean, the first thing that occurred to mind now, measles, for example. We have refugees. Measles outbreaks, can be devastating if you have groups of refugees. How can we maintain some of the essential foundation, the health workforce, critical. So yes, where is WHO's role in that? I think, of course, WHO, this debate has been now going on for years. Actually, I've only been at WHO for a little bit less than 7 years, but WHO is, of course, a normative organization, and that's probably our most famous roles. But in situations of conflict and emergencies, and this is very much the situation in our region, we have become increasingly operational because we don't have a choice. When you have parts of the world where there's no hospitals, yes, we were running field hospitals in Iraq for many years. Same thing we are helping with in Yemen. Same thing we are doing in some of the areas in Syria. We have to become increasingly operational, but it wasn't easy to learn.
Does it impact the nature of WHO, the fact that you're moving from a normative to an operational role?
Well, of course, it's gonna impact the nature of WHO, but it's going to require quite a bit of support system, quite a bit. There was a talk about legal structure earlier. There was a talk about how do we redefine the role of WHO. As I think Suit mentioned, that this is a member states organization. Member states have to help us evolve and help us better define our role, because we need to. We learned it the hard way in EMRO. We were dealing with huge funds and with donors, and we didn't even have the capacity to manage all of this. In places where you didn't even have mechanisms to disperse funds. We didn't even have banks. We didn't have any. So we had to learn, and it's a huge responsibility and accountability to actually be able to deal with all the operational needs and the pressures and the demands that require operational needs. So I think we need to go this way. I'm a practical person too, as Dr. Yodi mentioned. I think we cannot keep issuing guidance, strategies, and technical documents. We need to support countries, at least in building their capacity so that they can implement all these strategies. Otherwise, they're going to stay as documents in drawers and on tops of desks. Thank you.
Following up on what Dr. Hadjes was saying about the horrible reality of war and the weakening of health systems, I was wondering, how can public consideration be better integrated, embedded in responses to armed conflicts and humanitarian crisis? How can actually WHO support health care authorities and make sure that health is a precondition for peace?
I think WHO and us in the multilateral system in general is facing a major challenge today, in the sense that, and it was mentioned in the previous panel, is the fact that WHO is a member state organization and therefore is linked to political agendas. It's not dissociated from that. At the same time, when we talk about public health interventions in armed conflict settings, it is imperative that impartiality and neutrality are maintained. And impartiality meaning treating people based on needs and disregarding on where they belong or where do they live. Are they under the state control or under the control of an armed group? Those kind of considerations that really go out of the window when you are impartial. And when you are neutral, then you have the element of you don't take sides or you don't seem to be belonging to one specific side. You don't take part on the ideologies driving the conflict. And when you are a member state organization, necessarily you are linked to states. So that's a little bit of a challenge and a tension point that will need to be discussed and that will need to be worked out moving forward. And you say it's 7 years only, so it's a very, very short time. Is it doable? Yes, it's doable. So many of you are familiar with the Red Book, which is the guidance on delivering healthcare in armed conflict and fragile or very highly insecure settings. It's a guidance document for emergency medical teams produced by WHO in consultation with many different organizations that basically states a very, very strong abidance by humanitarian principles. So yes, it can be done. Now, what does WHO need to do moving forward? The first thing is really working hand in hand with ministries of health to make sure that the health space remains neutral. That disregarding, even when the weapons are being delivered, even when the fighting is ongoing, healthcare delivery should be maintained neutral. Because if that space is compromised, then the millions of people that are not impacted by armed conflict, by war, they will have further difficulties in accessing healthcare. So I think that's the first one. The second one is what it was mentioned in the panel before. At the end of the day, states are responsible for delivering healthcare to the populations, and WHO supports those efforts. WHO and states in general, a reminder that there are international humanitarian law obligations that protect civilians, that protect access to healthcare, that protect healthcare workers. So then it's also a responsibility of states to fulfill those obligations. And I will say one more thing is that in armed conflict, the first casualties of decreased budgetary allocations are health and education. And really, those are major drivers of deterioration of health outcomes. So this is another role, is to try to maintain on the discussions at government level and beyond ministries of health, the fact that health and education need to continue to be funded, despite the fact that funding is going to defense and security as well.
Thank you. Before opening questions to the floor, the question was raised actually before by someone in the audience about the global health for peace strategy. So how does this strategy, which will be considered at this 76th World Health Assembly, enable actually WHO to tackle its agenda in conflict settings, and what kind of support does the WHO need to move this work forward?
Yeah, no, thank you very much. I see Gianluca is actually leaving because I was commenting on some of his questions earlier. the way one of the questions was to him on the Global Health for Peace initiative. So they're actually two concepts, and it's a bit subtle nuance. But there is Global Health for Peace, and there's Peace for Health. Okay, and actually what we had addressed earlier, some of the examples that came up earlier were peace for health. I mean, in our region, we have really brokered some short, peaceful times, for example, to deliver vaccination campaigns in like areas that are under the Taliban, or in some of the areas in northern Yemen. Because this is really critical, whether to control measles outbreak, whether to be able to still deal with the polio. We are the only region in the world that has yet to eradicate polio, etc. This is peace for health. What we are talking about, and what will be the really subject of debate at the upcoming, because it's one of the controversial issues. We talked about some fireworks. The issue is whether, is this within really WHO's mandate to use health to broker peace? Even though this is something that we have been discussing now for years. I mean, we're discussing why are we talking about some of the big conflicts going on right now, like Ukraine and others, because we do feel, of course, that health is very important and is severely impacted. So I think what is this initiative was introduced now just before COVID, almost 4 years ago, by both by Oman in our region, by Oman and by Switzerland, and it's gathered quite a bit of momentum. Now what is going to the World Health Assembly is the roadmap. And the roadmap, because there's been some criticism that this is very theoretical, we need more practical. There are actually many lessons learned from other regions. The Latin American region, PAHO, back in the 80s when they used to have a lot of armed conflicts, there were actually many good examples of how they used health to broker peace in certain areas. I'm thinking now even for Sudan, we've been discussing, especially that healthcare facilities are targeted, is how can we really use this impact, severe impact on health to have to negotiate peace among the fighting parties, etc. But I think, of course, we're going to need a lot of support, and this is where the role of various partners on the ground, humanitarian, like ICRC, like all the other sister UN agencies, everybody, especially local institutions. I go back to country-based organizations that can support better, because not to use a cliche statement, we say think global but act local. We really need the local feedback we need the country ownership to support these initiatives. But I would like to mention, because I think Yodi mentioned this, the situation in some countries is not as straightforward. Like we are dealing with countries with divided governments. Yemen, we have two governments. Syria, we have two governments. So we don't even have one government to negotiate with, or to have that full ownership. And this is where I think WHO coming as a kind of a relatively neutral party can play a major role. But maybe to end, a couple of quick points to end with. The issue, what I mentioned earlier about, because that's very important to peace, health for peace, is DG, Dr. Tedros keeps one of his favorite sayings is that global health, universal health coverage and health security are the two sides of the same coin. And people wonder, I actually asked why. I think all countries should ask why. It's not always that obvious. It's because if you build health systems, then you can support both access to essential services, and you can also support, have the infrastructure in place to be better prepared for emergencies, which will protect health security just nationally and globally. So humanitarian support typically focuses on the acute humanitarian needs, but increasingly we need to also support building systems. Even in the middle, we cannot afford, we have countries like Somalia that has been in conflict for 20 years. You cannot just afford to only fund humanitarian. You need, while you are doing this, and we know this is difficult, build systems. If you build systems, it will ultimately lead to better peace, and it will at least help the country move towards peace. So that's one point. The other point I would like to say that, again, maybe linking to COVID, I think all of us still have COVID very much on their mind, and maybe, I'm really very critical usually of even our own role as WHO, but I mean, even 2 years ago, not even 1 year ago, we couldn't have imagined being here in a place like this, gathered again. I think horrible things happened during COVID, but the fact that we made it all, and this was with WHO leadership and bringing everybody on board to have a vaccine ready, to move on, push vaccinations, push other control, otherwise we would not even be here. A year ago, I couldn't even imagine that we can make it. So I think despite all what happened, despite the unfortunately many lessons that we learned the hard way at the expense, unfortunately, of losing, you know, millions of people, thousands of health workforce colleagues, we learned very, very important lessons. And some of the things that were mentioned about the greed and the power, and why countries cannot just rely only on international agreements, and they need to build their own capacity so that this never happens again. The lessons, I think, moving ahead post-COVID, we need to not let all the lives that were lost go to waste. Because we need to learn these lessons so that we will never again, I hope, in my lifetime, you know, have to deal with issues like what we dealt with during the COVID pandemic. But I'm very optimistic moving forward, despite the conflicts in our region. And I think WHO, together with all the other partners, and in our region, we have our motto is not only health for all, it's health for all by all. So that we can really make it.
Thank you very much. I think never again, that's the best way to wrap it up. I will just open the floor for maybe one or two questions. Please raise your hands, please. Yes.
Hello, I'm a researcher in University of Oxford and also a visiting scholar here. So my question is, I think just like that, the issue areas like vaccine deliveries, where the power that the vaccine, the funders and private sector have very strong power. So, so in the traditional humanitarian issue area, it's also that these funders have very strong power. So my question is, so in this issue area, so what should be or what is the role of WHO will work? So whether it could be set up its own agenda, or it just become another stakeholder in this issue area. Thank you.
Yes, thank you. So I think if I understood the question correctly, how can WHO basically support more access to vaccines in humanitarian settings, or is that because I'm sorry if I couldn't hear very clearly if that was the question. So what's the WHO's role in better supporting vaccine access? Yes, when it comes, yes, of course, WHO. Yes, of course. Now, WHO, I think, can play a very important role because they work together with the countries, with the member states, to define the priority needs. You know, so the needs really have to come from the country level, the priority needs, and WHO provides the technical support. It shouldn't be driven by the funders. This is where, and I think, you know, often what we have seen, and especially countries that are in conflict, that have weakened health systems, sometimes, you know, they just follow different agendas of donors. But what we are trying to do is to build the capacity at the country level so that they have the, you know, basically ability to define their priority needs, and based on that, you know, decide on where the funding should go. I mean, for example, the vaccine issues, you know, in many countries right now, whether it's in our region, in Africa, others, now they are going back to develop their own vaccine capacity, for example, because they realize that they cannot rely on the goodwill of all the rich countries, or definitely not the intentions of the for-profit big industry to do that. But I think WHO, together with the member states, can help put in place some maybe as part of the international health regulations or some other binding mandate where these issues that happened before with the inequity that resulted in the very severe inequity in vaccine distribution, for example, do not happen again. So there should be more systems in place to regulate that and not leave it to the goodwill of for-profit parties.
I can't. I think I would like to say something before we finish this panel, and it's in relation to the Global Health for Peace initiative of WHO, and it's the fact that the main intention is not really to have health or to have healthcare workers becoming peace brokers or mediators. That's not the main intention of this initiative. The initiative of this intention is to have health programming that is peace and conflict sensitive. So to really understand the dynamics of conflict, that really follows principled humanitarian action, and that allows a space that indirectly can foster an environment where peace can prosper as an indirect outcome. So health outcomes are the primary focus of this initiative. So you have the stream, which is being peace sensitive, and there is another one, wherever possible, to be peace responsive, to try to contribute to peace initiatives, but with a very big acknowledgement that this could have security implications, not only for WHO staff, but for healthcare workers and for humanitarian workers more generally. This also needs to be handled in a way that doesn't impair and doesn't create harm for the very populations we want to serve. So I really invite you to read the roadmap of this initiative, because it's very clearly spelled out that the objective is to really create a peace-sensitive environment, but pursuing health outcomes. And I think that is super important. And you come from the Middle East, you know how sensitive these issues are. So just wanted to wrap up with that one, just to clarify and to invite you to read the roadmap, because it's going to be discussed this week within the World Health Assembly.
Thank you so much. I think we are running out of time, so I would like to thank Dr. Martinez and Dr. Hadje for this wonderful panel discussion. And I give the floor back to Suri for a closing remark. Thank you.
Thank you so much to Stefan and our two fireside chatters, really, for your insightful views that have certainly helped me to understand better what we're looking at over the next 5, 10, 25 years in terms of global health and crisis and conflict. It's my task now to try to wrap up some of the key points from the last couple hours that we've spent together. And I wanted to leave you with 3 ideas. And to come to these 3 ideas, for me, what I've been thinking about in the back of my mind as I've been listening to the speakers is, what might WHO look like at 100? Which is a bit of a hard question to wrap our heads around. And in some ways, we can see that WHO will evolve. It will have to evolve. It will look very different 25 years from now than it looks today. And one of the reasons why it will have to evolve is precisely because of what we just heard, that we are in an era of constant conflict and crisis, and it doesn't look like this is going to change anytime soon. And so the role of WHO, whether it will be more operational than it was before, whether it will be more political than it was before, whether it will be able to retain its norm-setting function, whether it will be able to retain its perception of political neutrality and impartiality. I think these are big questions on the table, but certainly it will evolve. I think we also see a very ambitious vision for WHO, and I hope that it can evolve, indeed, to meet that ambitious vision. But there are some things I think that will not change. When we look back at WHO at 100, it will continue to be, as we heard in the earlier session, it will be a member state organization, a member state owned, governed, and hopefully financed organization, and this is a big question on the table this week. It's been on the table since the 1990s at least. Will member states actually live up to their responsibilities to finance the organization properly? But what we also heard, and this is my third and last major theme, who are the member states? We constantly hear WHO is its member states. WHO is a member state-driven organization. But who are the member states? And at the end of the day, what we heard, I think, very clearly is the member states are us. The member states is civil society. The member states are people. Member states are health workers. Member states are women. And so this idea of who ultimately is responsible for shaping WHO over the next 25 years into what we need it to be, and we need it to do many, many things for global public health, I think at the end of the day, it comes back to us. And if we really are serious about nobody left behind, as we heard earlier, this means that civil society has to be included, has to be at the table. Women have to be not only included, but supported, as we heard very clearly. And that this is really how we're going to achieve this ambitious vision that we've heard for WHO at 75. So on that note, let me close our open briefing. Thank you so much again to our moderators, to our speakers. We've heard from governments, we've heard from journalists, we have heard from civil society, we have heard from ICRC, which is its own category. We've heard from a number of different, from academics, of course, from a wide range of perspectives this morning, and that's something that I hope will continue throughout the week as all of you go out and engage in this very, very important week for global health governance. So thank you again to our speakers and moderators. Thank you again to our audience here in the room, and also those of you who've joined online for driving the discussion, for raising important points that we may have missed, for helping us to set the agenda here. I'd also like to thank, of course, always our wonderful colleagues at the UN Foundation. I don't know if 9th time is a charm, but for me, this was certainly one of the most eye-opening and stimulating events, and we look forward to continuing our partnership with UN Foundation in the years to come. I know there's a huge team at the UN Foundation, as there is here at the Global Health Center, that makes events like this possible, but in particular, I wanted to thank Kate Dodson and Molly Moss, who have been really critical in bringing this event together. From our team here at the Global Health Center, I'd like to thank Ellen Roscom, Alessia Nicastro, Bettina Zago, who could not be here with today, but has worked very hard to make all of this possible, Sarah Lafontaine, Moin, Hussein Alipur, there he is, Yulia Slavensky, and many other staff who helped make this event possible, including our events team here at the Graduate Institute. So I hope I have not left anyone out, but please join me in thanking all of our colleagues for making this event possible. Last but not least, it's my great pleasure to invite you all to join us for a bite to eat, a drink, a chance to meet each other upstairs in our cafeteria. Please join us for the reception. This is one of the best parts of the open briefing, and we hope to see you next year for the 10th year of this event. Thank you very much.